Okay, everyone, we're going to cover Chapter 51, Principles of Pharmacology. So this is one of three chapters that we'll be covering in the Medication Administration course. All right, and so some of the things that we'll talk about are the medical assistant's role in pharmacology and why it's important to at least have a basic working knowledge of medications and pharmacology. We'll talk about the 5 different categories of pharmacology and just a little bit of the importance of each as related to medication administration. We will kind of go through and differentiate some of the different drug categories, some of the drug names and their actions. There is a table in the book that goes through some of these major categories, and so although you're not writing prescriptions, the more familiarity you have with drug categories and names within those categories and what they actually do will make it easier as you progress along in your career and deal with patients. And because you're oftentimes the inner, you're the interface between that patient and the doctor sometimes. And so having that knowledge will be a huge benefit for you. Okay. We'll talk about the difference between prescription medications as related to something that's over the counter and also herbal drugs or herbal medications. Over the counter drugs are ones that you can go buy at the pharmacy. Some of them have been over the counter for many years. Others, after a certain period of time of being a prescription drug, can then be redistributed at a lower dose over the counter. Things like Prevacid and Prilosec. Naproxen, things that were normally by prescription only, once they're out there for a period of time, they can then be put into a lower dose and then sold over the counter. Not all medications can do that, but some can. And so it's important to know the difference between over the counters and some of the herbals versus things that are prescription, because even though something is over the counter or herbal, it doesn't mean that it can't be dangerous or that it shouldn't be reported to the primary care physician. And so even if somebody, when you're reconciling medications, when you're gathering all the medications someone's taking, it's important to include those medications because they can interfere with some prescriptions. And so it's important to know them. Anytime you're looking up information on drugs, it's important to use a credible source. So we'll talk about a few of the credible drug sources that are available. There's more than what's listed in the book, but we'll talk about a couple of them. We'll talk about a little bit about the DEA, what the DEA number is, and how it kind of relates to narcotics and controlled substances, and how to tell if something is a controlled substance, and then the different levels within the different scheduling levels within the controlled medications. Another important aspect that we'll cover is identifying the parts of an actual prescription, and we'll go through and break down what each area is. And then there are a couple of tables in the book that talk about abbreviations and symbols. And so starting to get a working knowledge of those will also help you be able to read and interpret, because a lot of times patients will come to you and go, what does this mean? And you need, even though you're not the one prescribing the medication, you need to at least be able to interpret. Okay. There's a short little bit, because we're talking about pain and narcotics in this chapter, some non-pharmacologic treatments for pain. And then we'll talk just briefly about vaccines and how it works with the immune system and the difference between immunization and maybe like a tox wave that's given. We'll get into a little bit more depth in that as we go further into chapters 52 and actually 53. Okay, so why does a medical assistant have to know about pharmacology? Okay, and so once again, you're not prescribing, you're not making decisions or advising people on what they should take per se, but it is important to be aware of the different kinds of medication classes and what they're used for, because as they come in and they're telling you things, if you're looking up every single medication, you don't know what it is, it makes it harder to display that confidence level and to actually be able to put a picture together, a full picture of this patient, okay? And part of your questioning as we went through in patient care, it's important to ask patients about all of the different medications they're using over the counter and herbal, as well as their alcohol consumption and any recreational drug abuse. So all of that gets tied in to medication reconciliation, okay? And many clinics, that is part of your role. Some clinics and doctors do it themselves, or the clinicians do it. Other places require the medical assistants to do it. Okay. Um, Medical assistants frequently assist in not only managing prescriptions via phone, but also renewing prescriptions or getting refills. Often, every time a medication needs to be refilled, an order gets sent to to the um, the doctor's office, and the doctor has to look at it and then decide whether or not it's okay to give refills. And so the medical assistants facilitate that and are an in between as far as that goes. And so that working knowledge again is important. Okay. And then lastly, but not leastly, you guys are the beginning and the end of that patient's journey through the clinic. And so they're going to ask you questions. And so the more you know, the better off you'll be. And once again, you're not necessarily going to advise or prescribe, but being able to answer the patient's questions about why they're taking those medications is important. Okay. So now we'll first look at pharmacology, and we'll look at some different aspects, or the 5 different aspects of pharmacology itself. And so from MedTurn, we know the word pharm means medication or drug, and ology is the study of. So pharmacology is the study of drugs or medications. Now we can kind of sub break this down into 5 other areas that are involved in pharmacology. Okay, so we have an area called pharmacognosy, okay, or pharmacognosy, which is understanding the actual characteristics of both natural drugs and sources as well as chemicals. Okay, many of our drugs, excuse me, are actually made of natural sources. Okay, aspirin actually comes from the bark of a willow tree. The foxglove plant contributes and gives and allows for the formation of digoxin. Digoxin is used for heart failure and is an antiarrhythmic or a rhythmic medication. So there are a number of different medications that actually come from natural sources. And so that's why knowing about herbal drugs, if somebody's taking a lot of herbals, it might affect what kind of medication is prescribed. And so that's why it's important to kind of have that knowledge. Then we kind of look at breaking down that pharmacology aspect into 2 areas, and we have pharmacodynamics. So dynamic kind of deals with what that drug does to the body. Okay, when we intake a drug, it's going to do something. And so that field is called pharmacodynamics. We can take that a step further and go to pharmacokinetics. Kinetics means to move, right? Movement. And so pharmacokinetics is what the body does to the drug. Okay, so we have what the drug does to the body, but then the body has to break that drug down, and that word is called metabolism. And so in order for that drug to actually be able to get into the body and do what it needs to do, the body has to break it down. All right, so that kinetics is the actual movement or the metabolism of that medication. And then the next step in that journey is the study of how the drugs are used to actually diagnose, treat, and or prevent disease. Okay, and so that term is pharmacotherapeutics. The word therapy means, therapeutic means therapy. And so knowing what drug to use, when, and for what problem is obviously one of the most important aspects of being a clinician. Not the most important, but definitely you don't want to give the wrong drug to somebody. So being well versed or knowing how to find out the information is important. And then the last one that doesn't begin with a P is toxicology. And so toxico means poisons. And so that's the effect of poisons or the effect of poisons on the body. Okay, and so obviously certain drugs, if taken in high amounts, can cause a toxic effect. Other things like chemicals like cyanide, strychnine are all poisons, and so they kind of fall into that toxicology too. They're not drugs that we give, but they can cause toxic effects on the body. Okay, and so kind of at the bottom of this is we use the DEA. That's just the drug. DEA is the drug. Is the Drug Enforcement Agency, and that's the government agency that actually oversees all clinicians that prescribe, administer, and or dispense any kind of medication, okay? We'll talk a little bit about more of that in a little bit, but all of these medications are overseen by the DEA, okay? All right, so this breaks things down just a little bit more as far as those areas of pharmacology. Pharmacognosy, remember we have natural products, okay? Many plants, animals, minerals, bacteria, funguses, leaves, bulbs, roots, all aspects of the plants and animals can actually be used to make different kinds of medications, okay? Antiarrhythmics, um, antibiotics. We have minerals and vitamins that come from natural sources. So there's many different natural sources, antibiotics and what have you, that come from these. Then there's times where they can actually develop something synthetically in a lab. And so we can look at something like penicillin that comes from a fungus or a mold and can actually make an antibiotic. We actually have other medications like Bactrim, which is synthetically made in a lab. And so some of our products can come, or some of these medications can come from natural sources versus synthetic formation in a lab. Okay. Another way to look at the pharmacodynamics is to actually look at how that drug works to produce a desired effect. We all want, when we take a medication, there's a reason for it. Okay. Some things like vitamins and minerals, we don't necessarily see an instantaneous change, but if you're sick with pneumonia and you're taking an antibiotic, you want to see how that drug works to produce that desired effect, which is less cough, less phlegm, and improvement in symptoms. And so certain drugs are going to need to, you actually want to see that desired effect, okay? And then pharmacokinetics is actually further broken down into 4 areas. And so when we look at the pharmacokinetics, remember that's the metabolism and the digestion of that drug or medication, so the body can actually utilize it. We actually further break that down into 4 areas. ADME. The A stands for absorption. Okay, and so absorption, when we're looking at that, it's like, how does that medication get into the body? And we have a number of different ways that medications can get into the body. We have an oral route, which we can take a liquid or a pill. Now, generally, when you take something orally, it has to go through the stomach, and it has to be broken down in the stomach and then absorbed into the bloodstream. And so it's kind of a longer way. It still works, but sometimes we need something faster than that. And so we can do certain things injectable-wise, shots. Those are quicker. They don't have to bypass the digestive system, or they bypass the digestive system, and it gets into the system faster, okay? Topical, we can also use the skin, okay? And we have a number of different medications. Certain progesterones and estrogens can be in topical form. We have topical steroids that can be used. They also have patches that kind of qualify under topical for birth control method. There's a lot of ways that you can absorb topically, and that once again gets into the system. It's not quite as quick as injectable, but it does bypass that stomach or digestive system route, and so it is a little bit faster. Then we have buccal and sublingual. Buccal, remember, means cheek, and so some medications you can actually put inside your cheek and it will slowly dissolve and then be absorbed. It's very similar to sublingual, but sublingual is under the tongue. The mouth is very vascularized, has lots of capillaries and blood vessels, so things can get into the system quicker than taking something orally, and then you bypass the digestive system as well. And so that's the absorption. It's like, how do we get that medication into the system, okay? IV also is here. I didn't put the IV in there, but IV can be a way that we put it in, and that's obviously the quickest. Distribution. So this is taking that medication. So once we've got it in, it's been absorbed in some way, shape, or form, it's in the system. Now we have to distribute it. So that means it has to be transported from where it was administered to a site of action that it needs be, okay? If I've got a cellulitis in my foot, okay, it's red, it's swollen, it's infected, generally, if it's infecting all of the tissues, something topical is not really going to be enough. So that person's going to need either something injectable or oral. And so if let's say they put you on Keflex to take 4 times a day for 10 days, That means that the distribution of the medication has to be put into the system orally, and then it's going to have to be broken down, and then it's going to have to get into the bloodstream, and then it's going to have to travel to that site that needs it, or that site of action, okay? And so medications also have something called a time of maximum peak. You look at how long it takes to be active, how long it takes to break down, and then how long it's actually at its maximum peak. Some things are very quick to their maximum peak, and if it's very quick, a lot of times the quicker it is, the more pills you have to take per day. If you have something that has a very long time frame or span, and it takes a while to get to its maximum peak, sometimes those medications can be taken less frequently. And once again, it just depends on the medication, okay? Then the next step is metabolize. So we have to metabolize or break down these medications into a smaller product so that it can actually get to where it needs to be and actually work. And so the liver and kidney actually play a huge part in this. I know the first thing you think of with metabolism is thinking about the breaking down in the stomach, which that plays a part. But once these medications actually get into the system, the liver and kidney actually play a part in breaking them down so they can actually be utilized. They run through the liver and they get distributed where it needs to go. And then at that point, whatever's left over, or once it's done its job, then it has to be excreted. And so there is a manner in which the drug is eliminated from the body. The majority of the time it's in the urine, but you can also have parts of them, little bits of the medication. Certain medications can be excreted in the feces, sweat, saliva, and breast milk even. And so that's why we'll talk a little bit about pregnancy categories and breast milk, but some medications actually can be expressed in the breast milk. And so you have to take all of those things into consideration when you're choosing a medication. Okay, so now let's break down pharmacotherapeutics. So we're now looking at the next step. Now we've got to go, how do we utilize these drugs to treat a disease? And when we're looking at that, we have to look at, number one, an indication. What is the purpose of the drug? Okay. And generally, drug companies, when they're advertising medications, have to actually know what they're treating. So they have to go, well, we're using this for this specific purpose. And then the FDA has to go through and look at all their data and actually approve it. Very much like what they've done with these COVID vaccinations. They had to go through and develop a medication, and then they had to find people to volunteer for drug trials, and then they had to administer those trials, and then they have to do testing on that to make sure that we're actually getting an adequate response. And that's where you're seeing all these efficacy rates of 90 to 95%, like the Moderna and the Pfizer shots are two-prong shots, but they have about a 95 to 96% efficacy rate. And so that's because they did models, they drew blood, and they actually were able to come up with percentages on how well those vaccinations actually created an immune response. Now that's not exactly the purpose of a medication, but drugs are done the same way. They take people in for drug trials. They usually have a group that's getting a placebo or a sugar pill that has nothing in it, and then another group that actually has the medication, and they study side effects and efficacy rates with both of those groups and come up with data so they can actually submit it to the FDA and get approval for the indication that they're trying to get. Now, sometimes when you do that, you'll actually find that a drug has a secondary effect even though it wasn't indicated for something. And so occasionally medications will be used for something called off-label. Like, I think the book talks about Benadryl. There's a couple of other things that are used that way, but Benadryl is prototypically an antihistamine. It's used for watery eyes, itchy throat, runny nose, and sometimes even skin allergy manifestations. But a side effect from it is that it causes fatigue. And so some people will use it because oftentimes people get very drowsy with it. And so it can be used at times in certain situations to help people sleep if they need it. It's a very mild effect as opposed to other sleeping agents, but that's an off-use drug for Benadryl. Okay. So then the next component we look at is labeling. And so labeling is basically all the known information about a drug, and every single medication that, if you've ever gone to the pharmacy and picked up a drug, it's got all sorts of information on the label. Okay, and so there is a page in here that talks about labeling and all the information on it. And so being able to look at a medicine bottle and be able to recognize the aspects that are on there are important. Okay, and I think the page that we were talking about with that is in the book on page 1133 and 1134. It kind of gives you an idea about labels and the information that's on there is being able to figure out the name of the drug, how it's administered, when you give it. All right. And then on top of that labeling, there's also safety. And so when we look at safety, we want to make sure that we're taking something that's going to treat or affect the disease that we want to treat, but not cause more damage. We don't want to take something that cause for one thing and then have it give us a ton of adverse effects and side effects. And so safety profile is a very important thing so that people know what their risks are when they're taking something. And they kind of break the safety guidelines up into two different categories, a side effect versus an adverse effect. A side effect is something that's rather minimal. Okay, it's kind of common. It's usually mild. Sometimes a little, nausea, or if you have a local effect where after you get a vaccination, there's maybe a little bit of soreness. But side effects are usually very mild and common and not too bothersome and not going to affect you too much. Adverse effects are a little bit different. Adverse effects would be more of an allergic response to something, or a severe thing. If somebody took Benadryl and didn't just get a little tired, but literally was in a stupor and couldn't concentrate, that would be an adverse effect. Okay, and so adverse effects are usually more severe and not as common, and usually might even indicate needing having to go back to be evaluated for it. So there is a difference between a side effect and an adverse effect. Okay. And then we look at the word efficacy. And efficacy is really important because it really looks at, whether or not the medication that you're taking is actually doing its job. Okay. And if it's not, why? And so efficacy rate is important because if we look at something, if something's got a 95 to 96% efficacy rate, then it would be worthwhile taking it. If something has a 20 to 30% efficacy rate, you'd have to reevaluate and look at the side effect profile and weigh the benefits versus the cons, or the pro versus the cons on it. And so obviously the higher the efficacy rate, the more of a value or therapeutic value it would have, and the more likely you would be to take it. You would want to take something that has a 95% efficacy rate versus something that has a 30% efficacy rate if it's the same thing, because you want that higher therapeutic value. Okay. And then we look at kinds of treatment or kinds of therapy. And this kind of goes into the different modes of pharmacotherapeutics. Sometimes we're taking something to deliberately treat a specific infection. Okay, we have acute is the first one. And so something acute is when a drug or a medicine is prescribed to improve something that's life-threatening or serious. Okay. If someone's having an anaphylactic reaction, then epinephrine can save their life. That's an acute response. Empiric is used kind of according to experience or observation. Okay, we're kind of giving it empirically until we actually find out more information, so that we can find out what's actually needed. Okay, maintenance is given if we're trying to prevent an outbreak of something or prevent an exacerbation. If someone has asthma, then there's a couple of different kinds of inhalers they can use. They can use a rescue inhaler that immediately bronchodilates and allows more air in, or they could use maintenance, which is usually steroid based, that is used over a prolonged period of time to decrease the inflammation to prevent those outbreaks. So some things can be used for maintenance therapy. Then we have the word palliative, and palliative is something that's given to reduce the severity of symptoms that might be accompanying a disease process. Pain medications, Advil, Tylenol, can be considered palliative because you're trying to decrease symptoms that are going along with the disease process. Okay. Prophylactic is something that's used in order to prevent. It's a little different than maintenance because it's actually used to prevent something. Immunizations, birth control pills can all be put in the category of prophylactic treatment. Replacement treatment is usually if you're missing something. If someone's got hypothyroidism or their thyroid doesn't work, then they have to take supplemental thyroid. If someone is diabetic and they don't have any insulin at all, then they have to take medicine to replace that insulin. And so some of our disease processes actually require a complete replacement medication situation. Then we have supportive. Supportive is just kind of providing support. That until the disease process wanes. And then we have supplemental, which would be like our vitamins and minerals that actually supplement our diet with things that our body may or may not be getting enough of. Okay. Okay. So now we'll kind of move on to drug names and categories. And so the tables that are here, table 51-1, is about 2 or 3 pages long, and it looks pretty overwhelming, but I want you to just start to kind of look at, you might want to even just look and go, oh yeah, I've heard of those medications first. Take a look at it. You're not going to be tested on every aspect of this, but these pages are something that the more you know, the better off you'll be, okay? And so I will want you to kind of take a look at these. What it does is it goes through and categorizes the drug category, what it actually does in the body, and then gives you some examples of both generic names and trade names, okay? Now the difference between a generic and a trade name is the generic name is what's considered to be the official or non-proprietary name, okay? It's usually the first manufacturer that came up with that medication. It's usually less expensive. And normally it will be given by pharmacies unless it's otherwise specified. Any manufacturer that comes out with a new drug has a patent for 17 years. Okay, after that 17-year mark, then other companies can come in and manufacture it. And that's where you start seeing multiple different trade or brand names. Okay, so generic names, an example of a generic name is amoxicillin. But it's actually been, got a couple of different names, Amoxil, Proamox, and so there's a number of different names that other companies have come in and replicated it, and then they can sell it under a different name. And so prototypically, those trade names are more expensive than those generic. And so a lot of times generics are much cheaper. There are a few rare case scenarios where the generic medication isn't as good as the brand name. But most of the time, generics are usually the better way to go under most circumstances. Most insurance companies would prefer to accept or give generics rather than a trade name. So once again, trade names are the brand names. Those are when other companies come in and actually start replicating that medication. They just put a new name on it. So that's oftentimes called the proprietary name. The chemical name is sort of the actual chemical makeup of it. And if you look in some of the, I'll talk about the PDR in a little bit, the physician's desk reference, some of those drug book sources will talk about the chemical name, and that's actually the drug chemical makeup of it. And so it's usually very long, prolonged name. You don't usually see those, but if you ever look in the books or the farm books, you'll see those chemical names as well. Okay. And so when you're looking at these drugs, they will categorize them by action on the body, the actual therapeutic effect, or how the body system is affected. And that's what this table does. It gives you a drug category, an action or what it does on the body, and then gives you some actual trade names that you might recognize. Okay. So as you go through this table, I would not sit down and try to memorize everything, but having a basic knowledge of the drug categories and what it does, and then maybe one or so drugs that fall into that area. This is something that will be an ongoing, evolving process for you to add more drugs as you go through. Like I said, the more you know, the better. Okay. Okay. And so let's look at some of the regulations on drugs, okay, or regulations and drugs. And when we're looking at the FDA is the Food and Drug Administration. So that's the body that oversees all drugs and all prescriptions or all drugs that are written for. Okay. The DEA is more specifically for controlled substances, to where the FDA is all drugs in general. And everything has to go through the FDA in order to get approval so that it can be marketed in the United States. Okay. If you look at other countries in Europe and some other places, our FDA has a tendency to be probably the strictest governmental body on medications and administration and the ability to actually approve and distribute those medications. And that can be a good thing and it can be a bad thing. If something makes it through the FDA, it's usually very highly vetted and researched with stats. And so you generally, I'm not saying it's perfectly safe, but we have a tendency to be a little stricter. And so you know that it's been through a number of years of tests before something can actually be released. Okay, if you go to Europe, Europe actually doesn't have as strict regulations. And so a lot of times people will go over there when they want experimental drugs because it takes time for the FDA to actually approve things. Okay. All right. And so over-the-counter drugs aren't really regulated. They're non-prescription and they're not regulated in the same way that prescription drugs are. And so you do have to be careful. Taking that, people can still take too much of over-the-counter drugs, and there can still be side effects from those, but prototypically they are given at lower doses, and so it doesn't tend to be the same issue as prescription drugs. Okay. Now, when you're going to use, when you're looking at prescription drugs, one of the more common sources that we'll use for information is called the PDR. It's the physician's desk reference. This is probably the formulary that I'm the most familiar with and have used. It's extremely thick. It's thousands of pages long, and it has every single bit of information that you'd want to know about every drug. Okay, this book is printed annually, and they sometimes give supplementals in the middle of the year if other drugs or if things are found out or new drugs come out to supplement the annual release of the annual distribution of each manual. Okay. And so it's important to know that these prescription drugs have to be ordered by a licensed healthcare practitioner, a doctor, a DO, or an MD, a PA, a nurse practitioner, or a midwife. Okay. And so you have to have a state license as well as a DEA number to prescribe these medications. Okay. Now the book goes in and talks a little bit about pregnancy categories. And so it's important to realize that even though the FDA goes through and does a lot of testing on our drugs that come out, not a whole lot of people want to be the volunteers when they're pregnant to try medications. And so they had the older classifications for safety in pregnancy were on a ABCDX level. And so they would use those letters to correspond to safety and efficacy in pregnancy. Okay, A and B being safe, or as safe as they could say. C is sort of an in-between stage where you'd have to weigh pros versus cons. A lot of the studies have been done on animals and not humans, and so that's why it's not an exact correlation as far as what the side effects will be. But if something causes damage or problem in an animal, then there's a likelihood that it's going to cause a problem with a human. And so that's why they usually use, a lot of this came from animal studies. D and X are definitely ones that you want to avoid. D is a category saying that in moderate or large amounts it could cause a problem. X means it definitely will, and you don't want to take that drug and get pregnant. Okay. They've actually changed the category a little bit. The book talks about it on page 1131, where they've changed. They don't really use these ABCDX categories anymore. They kind of classify it according to pregnancy, which includes labor and delivery and all the label requirements. And then they have a lactation, and then something called female and male reproductive potential. And so they look at drugs and the potential for side effects. Okay. A lot of this is based on just prior history. It's not done on specific studies, but just reports of what people have noticed when pregnant patients or lactating patients have taken these medications. And so it's always important to be wary. And when you're giving out medications, especially obviously when you're dealing with females, if finding out whether or not that person's pregnant. And so that's why that last menstrual period, and if there's any chance of that patient being pregnant, to order that pregnancy test, because we don't want to start giving something out like an antibiotic that's problematic and have that patient be 4 or 5 months or 4 or 5 weeks pregnant. Okay. And so we have to take those into consideration when we are administering drugs. Now, I mentioned earlier, I just mentioned in that last slide, the PDR. This really is I'll say the Bible that's used by most physicians and clinicians. It is published annually, and it really goes through every possible aspect that you could think of. It has the chemical picture, it has the generic name, the brand name, all the trade names, the indications, side effects, adverse effects, dosing, and it gives every single possible side effect and adverse effect that came out of the studies that they found when they actually submitted it through the FDA. And so nothing is 100% safe. And so even if something came in less than 1% of the time, it is marked in the book. And another word that I hadn't mentioned before is contraindication. Contraindication is a word that implies that medication is really, I'll use the word prohibited in certain conditions. And so what a contraindication means that they have found that if you take that medication in a certain disease process or in mixture with another medication, that it could really cause harm. And so if something is contraindicated, like a medication is contraindicated in a certain disease process, it is technically prohibited to give it. Okay, so contraindications are definitely important to know. There's a couple of other sources that can be used. The United States Pharmacopoeia, which is like a national formulary, and then which is administered, I think, less frequently, 4 to 5 years, to where the PDR is done every year. And then they have the American Hospital-Based Formulary Service, and almost every clinic system, Scripps, Sharp, Kaiser, and most hospitals will have their own formulary, because certain insurances have certain medications that they cover and certain ones that they don't. And so those hospital formularies are also a source to be used. But the PDR is sort of the Bible of medications. And with our online and digital use and hand device stuff, we now have other things like Hippocrates and some of these online downloadable versions of medication information that give lots of information too. And so that can actually be downloaded on a device, and it can give you a lot of the same information that the PDR does. All medications come with a package insert, and I don't know if any of you have ever gotten a medication and then you go to pull out the medication, and this long piece of paper that's like 5 feet long, that's all wound up, and a little ball kind of pops out. And the next time you get a medication, or if you take anything regularly, you might want to unpeel that and unroll it. And it's very similar to the information that's in the PDR, but it's more condensed. But that gives you all of the information that you need to know about that drug as well. It's just a little bit more technical than maybe what the pharmacy gives you on the front of it. Say, hey, if you get this, and this, please call us. Okay. All right. And then also drug labels. It's really going to be important to be able to look at a drug label and be able to kind of decipher what everything means. When you're looking at drug labels, it gives you not only the name, and oftentimes it'll give you the generic and the brand name, the form that it comes in, liquid, pill, what have you. It gives you the dose strength, how much is contained within that container, whether it's the amount of pills or the amount of liquid. ROA is routes of administration, how you're supposed to take it, any warnings, storage requirements. Do you need to keep it in the refrigerator? Does it need to be out of the refrigerator? So all of those things are listed on the drug labels. And so being able to go through and take a look at that is important, because patients will oftentimes come in and ask you to help decipher what's on that drug label. Okay, so now we'll kind of venture a little bit into controlled substances. A controlled substance is something that has an addictive potential. Okay, and so they classify any kind of drug that has an addictive potential in this category of controlled substances. And in 1970, they came up with Comprehensive Drug and Abuse Prevention and Control Act. And so this basically helped establish the DEA. Okay, and so what that did was it allowed for more oversight of controlled substances. Okay. When you see the term opioid, opioid is just a natural or synthetic drug that produces an opium-like response. Okay, it is synonymous with a narcotic, but that's a term that's used more by police and drug and governmental agencies to describe opioids itself, because you have a number of different types of opioid medications, so they clump it together and call it narcotics. Okay. When you're looking at the labeling of a controlled substance, you'll see it marked as a big C, and then there'll be a Roman numeral in the middle of it. And so they categorize controlled substances by 5 different classes. And so the Roman numerals go 1 to 5. If there's a case scenario where you're in a clinic setting that administers samples of controlled substances, then there's a extensive record keeping and inventory that has to be done in order to document everything when it's given out and what you have. I don't think there's a whole lot of places. If you're in a pain clinic, that definitely might be there. Other places probably don't do this as much because of the opioid crisis and all of the, addictive properties that these medications have. 10, 15, 20 years ago, doctors tended to hand these out a lot more freely, but the amount of people that have become addicted and have died from these has really put a large constraint on this and has made everyone much more aware. We still have a lot to do, but it has brought attention to it so that people, doctors and ERs, especially ERs, are not handing out the amounts of medication as easily as they used to. That doesn't mean that there aren't disease processes that need a controlled substance, but you just have to monitor it closely. When you're disposing of these drugs, if you have samples in your office, there is a specific form that has to be administered in order to dispose of packaged medication that has expired. Okay, you don't ever want to put any kind of substances in the trash or flush it down the toilet. Okay, these need to be dealt with by a DEA form and should be dealt with appropriately. Okay, sometimes you'll hear, I've heard that they've talked about ways of getting rid of extra medication. You could put it in a plastic bag and put it in a little bit of water and dissolve it. If you have to get rid of it, that's the safer way to do it. But the fact of the matter is we don't want this stuff in the environment, and so we have to make sure that we deal with it appropriately. If you're on a personal level, there are pharmacies that have drop-off boxes that you can just put old medications in there. And there's usually community events by the police department and what have you that oftentimes will have these around the community. And so that's a good source to use to get rid of it. But if you're in a clinician or medical setting, you have to file a DEA 41 form. Now, when we look at the classification of these substances, we do classify them 1 through 5, okay, and they're in Roman numerals. The lower the number, the higher the abuse of potential, okay. So we look at Schedule 1. Schedule 1 is the most, has the highest abuse potential, but this is not a classification of medications that we write for, okay. No prescriptions are written for Schedule 1, okay. Schedule 1 drugs include ecstasy, heroin, LSD, things that are considered more recreational abuse kind of a thing, and so those are not written, okay. Schedule 2 is the highest that we can write for. There is still a very high abuse potential, but these prescriptions must be written by a DEA licensed physician on a specific pad. They usually call them triplicates. You can't call in Schedule 2 drugs. There's rare circumstances to do that. But part of that is because we don't want anybody just calling in and using a license number and being able to get narcotics easily or to get these Schedule II drugs. And so there's a very specific process that has to be done. It can't be just on a regular prescription pad, and it has to be written in a specific way. Drugs in that category are basically morphine, Demerol, fentanyl, very strong addictive medications. Schedule 3 is a little bit lower abuse potential than 1 and 2. Drugs in this category are analgesics like hydrocodone or Vicodin, Tylenol 3, some anabolic steroids, and these have lower potential, but it's still there. And so you can see on page 1136, they kind of talk about the different guidelines that go along with it, how you can write them. 5 refills allowed in 6 months. It has to be a handwritten prescription by a physician. Okay. Next category down is level 4 and then 5. These have the lower abuse potential. There's still abuse potential there, but it's lower than the other ones. Category 4 include things like benzodiazepines, which are anti-anxiety medication, Xanax, Librium, Valium. You do have to be careful with those. They still do have a fairly addictive property. Once again, this prescription still needs to be signed by a physician. You can call these in, but most of the time you're going to limit the refills. Okay. And then we look at Schedule 5. We're actually dealing with things like Lomodal, some of the antidiarrheals, and cough medications. They can actually, Phenergan and Robitussin can actually put a little bit of codeine in their preparations, and that can actually help someone that's got a really nasty cough that your run-of-the-mill regular antitussive isn't working for. Okay, but once again, they're all scheduled. Okay. Okay. So we covered those. So now we're going to kind of look at prescriptions, and we're going to do this in class a little bit. We'll kind of break this apart so that you can actually learn to decipher the prescriptions. And so when we look at the prescription, there's a number of different pieces of information that are there. Okay. Usually the prescriber's information is going to be at the top of the sheet. That could be the doctor's name. It could be the address where that doctor's at, as well as information like their state license number and their DEA number. Sometimes that's at the bottom of the sheet, other times it's at the top. It kind of depends on the facility. Then below that, you'll have the patient information. So there's a specific line for that. A lot of places will use stickers so that you can't, as opposed to just writing the patient's name in there, so that the pharmacies actually know that that patient was seen at a specific clinic and was given that and didn't just get a hold of it and run off with it. So the patient's name, age, date of birth, and sometimes the address and phone number. Phone number is important so that the pharmacy can get a hold of the patient if there's any questions. Okay. Then as we travel down to the middle, we'll see a big R and a little X. That's an abbreviation for treatment. And so usually next to that will be the medication prescribed. Underneath there, you'll have something called subscription, which is the instructions to the pharmacist regarding the dispensing of that medication, including if you're going to use a generic or not, and if there's any refills. In between there, you have something called the signa, and the signa is also known as the transcription, and that's actually the instructions to the patient. 1 tablet 3 times a day for 10 days. Okay, so that's known as the signa. And then at the bottom, you have to have a handwritten signature. Most places require a handwritten signature and a stamp of some sort so that they know that that individual is actually a healthcare professional. It must be in ink. You cannot write any prescriptions in any form of pencil. If something is actually included in an electronic health record, EHR, we now have e-prescribing where that medication can be directly sent to the pharmacy and it doesn't even touch the patient's hands. That's actually the safer way to do things so people are not losing prescriptions or trying to add numbers to it or take numbers away. And so that's a big part of what you guys will be dealing with out in the field, but occasionally you may still get some written prescriptions that are done. So that it needs to have a date, it needs to have a signature, it's got to have a state license number, DEA, there's actually something called an NPI number, which is a national provider number. A lot of Medi-Cal and Medicare patients, if a physician sees Medi-Cal or Medicare, they also have to have that national provider number on there as well. And then the date is important too, okay? If you're in an area that has prescription pads, it's really important that these are kept locked up. There used to be times, I remember even back when I was not even that long ago, where doctors would just leave them in drawers on top of their counter. It's really important they're tightening down on this and making sure that these things are locked up, because once patients get a hold of them, they just start writing whatever they want. And if a pharmacy is busy and not paying attention, they might end up giving out medications that they shouldn't to patients that don't know what they're doing. So, okay, so I kind of mentioned e-prescribing already. That's when it actually goes directly to the pharmacy without touching the patient's hands. Once again, that is the more efficient method. That way too, you keep track, and it kind of localizes the pharmacy so that patients are not going to multiple different pharmacies. If they have one pharmacy on tap, then they're going to the same place, and that way if there's drug interactions, the pharmacy can track it. The other thing that we will provide is that I'll talk about a little bit is telephone prescriptions. You can't generally telephone and schedule 2 drugs. You need a special triplicate form, but other medications can be called in. And sometimes the doctor will do that. If the patient's left and isn't there, sometimes they'll say, hey, can you call this into the pharmacy for the patient? And so we'll go through telephone, prescription, transmittal. Things that are important are to include the name of the clinician with their license number and the DEA number if you're calling a new pharmacy that doctor's never prescribed to before. You want to always tell them who you are and what clinic you're calling from, and a phone number or a fax number that they can reach you. You want the patient's full name, date of birth, address, and phone number. And then you're going to describe the medication as it's written basically on the prescription pad. Amoxicillin, 500 milligrams, 1 tablet, PO, 3 times a day times 10 days, number 30, no refills. And so you're going to have to spell all that out verbally so the pharmacist can transmit it exactly how you transcribed it. Okay. Okay, so we kind of talked about all those aspects. We will review the prescription in class, and we'll review the telephone transmittal in class as well. So there are some other, here we sat talking about pain and opioids and narcotics, and it's important to realize that those medications have a place, and it's important to not undertreat someone for pain. If someone's in true pain, you want to make sure that they're being treated for it, because it can make recovery much more difficult if that person's in excessive pain. And so it's just become an evolution of medicine to start being a lot more careful about who they give it to and how much they give it to and when it's given, to make sure that they're monitoring it. And so that is important. Talking about those aspects of things, there are other modalities that can be employed. Now, if someone is terminal from cancer, going to a chiropractor may not help much for that pain. And so obviously this stuff has to be taken in context. But when you're looking at non-pharmacologic pain management, there are other things that can be done or utilized that can help decrease pain. You can also use other things like Tylenol and Motrin and anti-inflammatories that are less that don't help with severe pain as much, but can help with mild to moderate pain. Other non-pharmacologic forms are chiropractors. I just kind of mentioned that. Spinal adjustments for neck and back pain can be helpful. Massage can promote healing through relaxation. Acupuncture uses little needles, and there's a whole science and a whole area of medicine under acupuncture. It can be kind of expensive, but a lot of people swear by acupuncture. Yoga and even Tai Chi can be very therapeutic for people that have certain types of arthritis and muscular conditions due to stretching, postures, exercises, stimulates the lymphatic system, and really helps helps increase, it can increase flexibility and really kind of help with arthritis and joints and pain and muscular pain. Meditation, a lot of people swear by meditation. It really kind of helps to restore a balance with physical, emotional, and mental well-being. There are some people that use hypnotism. Obviously, you have to be in the right frame of mind. Not everybody can be hypnotized. Some people are a little bit more suggestive than others, and you have to be willing in the process. And usually you have a specialist do this. But some hypnotism can help overcome pain and certain addictive issues. Glucosamine is a medication that actually can be used to increase lubrication of the joints with arthritis. It doesn't help with all. If somebody's got rheumatoid arthritis, it's not beneficial, but you've got wear and tear, osteoarthritis in the knees and the back, the glucosamine can help to lubricate the joints a little bit more and help out. And then we have things like magnetic therapy and biofeedback that can also help to treat chronic pain and block pain perception. Okay, lastly, we'll talk a little bit about vaccines. Now, we're going to go into this in a couple of different lectures. We'll talk a little bit more about vaccines in Chapter 53. But we need to know that a vaccine is something that is made from a microorganism, okay? That could be a bacteria or a virus. It is administered to an individual to either decrease the sensitivity to or increase the immune response to some sort of infectious process, okay? Just like we have going on now with COVID, we're taking a killed version of the COVID or a severely dead version of it and then administering it into an individual to mimic having the infection, but it's not enough to give you the disease, but it's enough to mount an immune response, okay? And so we can do this with a number of different bacteria, pneumonia, varicella, all of the immunizations that you guys are hopefully going through and getting done for Complio. So all of those obviously are things where we administer some sort of either dead microorganism or what's called live attenuated, which means it's severely weakened, okay? And when we have an immunization that's made from an organism, that is where the word vaccine comes from. There is also something a little bit different than a vaccine. We also have something called toxins or toxoids. These are temporary antibodies that can be given to an individual to help fight off an infection that they've been exposed to, okay? They're usually an anti-serum from an animal or a human, and it gives a temporary boost in the immune system so that that person doesn't get the infection. Let's say someone was stuck by a needle. Maybe everyone that goes into the healthcare profession has to be vaccinated against hepatitis B, but a few of the toxoids that are available are for hepatitis B, immunoglobulin, there's hepatitis A virus immunoglobulin, and there's even a tetanus toxoid. And so these anti-serums can be injected if someone were exposed and hadn't had the vaccine to give them sort of temporary antibodies so that hopefully their body will fight the infection off and not get it. Now, the problem is it's not the same thing as a vaccine. If someone is exposed to hepatitis A and they've never had the vaccine, but they don't want to get sick, they'll go to the doctors, they'll give them a Hep A immunoglobulin, and that will give them temporary antibodies for 2, 3, 4 weeks so that if the infection was going to kick up, it would help fight it off. Now, that doesn't mean that they couldn't get it again later. So these toxoids are temporary. They can be used, but usually they use it for severe issues. A lot of people can have reactions and allergic reactions to these anti-serums, and so using human anti-serum is usually more advantageous than using animals. And it's usually more for severe things, not just run-of-the-mill. You wouldn't make a toxoid to like a cold. It wouldn't be worth it to do that, but something that's more severe, more long-lasting could cause a potential problem later on. These toxoids can be used, okay? We'll go into a little bit more information about the different kinds of vaccines when we get to Chapter 53. Okay, so we kind of ended here. I talked a little bit too long, but things that are important from this chapter are the role of the medical assistant, review the reasons why medical assistants need to understand pharmacology and have a basic knowledge. Make sure you go through all of the words that we talked about: pharmacology, pharmacognosy, kinetic, dynamic, therapeutic, and toxicology, okay? And then the different areas that are sub-areas that are underneath there. knowing a little bit about these drug categories that were in those tables, 51.1, I think. And so making sure that you look through that, understand some of the characteristics of over-the-counter and herbal drugs. You don't need a prescription, but they still need to be included in a drug history because it can make a difference with other prescription medications. We talked a little bit about the registration process, DEA regulations, and controlled substances. Being familiar with those and those names are important, okay? Prescription, we will take time and go through that. You really need to be able to read not only a drug label, but also be able to decipher what's on a prescription. And then we talked about some of these other areas. So I'm going to stop for now. I think an hour is more than enough. And I'll see you in the next lecture for chapter 52.